Thank you. Ready?
If there are any questions, you can also interrupt in
Yes.
the middle of the talks.
Thank you. And because I have to moderate one more session, so I thought I'll just, at the end of this, that session is going to be the end, so I thought I'll just start my talk. Usually in a normal keratoconus ICs, we go by a flow. I mean, what is KC, what is cross-linking and these things. But I think this crowd has already been doing things. So we just had to go into the very specific details of what problems we face. It's more of a problem-based learning kind of a meeting is what we plan to do. These are my financial interests, which I get to receive grants from. These questions are the ones which keeps coming to us when we are doing cross-linking. I'm getting more haze. My outcome is, I do not know what my outcome is. I'm not really sure whether I have an infection or an infiltrate or an excessive reaction. I'm not getting a proper demarcation line. What is progression? So whole idea of this next 45 minutes of me and my colleagues who are going to speak is trying to understand each one of them and trying to give a reason. Why do you get all this? Why do I see all this? The first question which needs to be answered is, should we consider keratoconus as a non-inflammatory disease? That's the first basic question. Once you answer this question, either way, you will probably get an answer which will help you to manage your patients better. It's a simple surgery, but outcomes are quite different. We assume, because it's quite easy for us today to just say that you'll come back after a year or two, we'll know what's happening. Patients are going to come back. They're very young. They're going to come back to you for the rest of their life. And if you're not knowing something, it's criminal. So there are different ways of how people rub their eyes. And for the last 150 years, this has been the mainstay of how KC was looked at. You rub your eyes, you get keratoconus. You don't rub your eyes, you don't. We know that it's not true. So it's always been a question of chicken and egg, which we don't know which comes first. Do you rub your eyes and then get KC, or KC makes you to rub eyes? So from a very cell biologist point of view, this was a paper by one of my fellows. He presented it yesterday. What really drives keratoconus? It's a very favorite paper of mine, even though they didn't win, doesn't matter. But it is important because this paper looked at, why do you rub your eyes? So when we looked at all this tests, what we did with some microarray analysis with the tears and all that, we found that patients who did not have any eye disease, this is a grade of keratoconus, we can test IG in the tears. You can see that it looks like your topography. It is high. That means that patients who have no allergy, who are otherwise asymptomatic, still have high levels of tears, which matches with your grade of keratoconus. So the pathology just may not be an allergy, but pathology could be something inherent, something the patients may have some atopic tendencies. And when we compared with the keratoconus with allergic eye disease, the grades did not really match. It was not as simple as we see in this. So the translation application is, I'm just going by questions. Why do you rub your eyes? Because either before surgery or after surgery, we're always very keen on rubbing the eye business. So when you ask a patient and he says that he's rubbing your eyes and he still does not have any symptoms, it is important that you have to manage it like an allergy, even though you don't have a classical forms of allergy out there. Or when patients do have something else, but not the eye allergy, we have to manage it systemically. We have some cases on this in the end of the presentation, so I'm not going deep into this. But the role of immunologist, basically to answer what do I do when my patient rubs the eye before or after cross-linking, the first thing is you have to manage it with one important person is immunologist. You have to find immunologist, a physician, whoever has an interest in immunology, you need to keep them on the board. It's like for a keratoconus person, if you're doing a lot of keratoconus work, one thing I request you to do is to find a good physician or immunologist or any allergist person who can help you out. When you look at predictors of good and bad cross-linking and what is good and what is bad, for that you have to understand that the eye, the keratoconus or your normal cornea, this applies, the same model applies for refractive surgery also. There are cross-linking agents already existing in your eye. They call the lysyl oxidase is one of the known ones, but there are many more compounds. That means that your eye is getting cross-linked as we move on. Who is doing the cross-linking? We are not using riboflavin all the time. It's because that there are proteins, there are cells, there are machinery which God has provided us to cross-link all through your life. And it's not only in your eye, it's in your skin and every other part of the body, wherever it's required. So what really happens is, each person in keratoconus has different level of these proteins. All of them may not have the same proteins, or all of them may not have the same endogenous. We call it as endogenous cross-linkers, which is inherent. It's like an endogenous endophthalmitis. It is something to do with your inherent property of your eye. So I gave my defense for my PhD on this. This is my favorite slide about each and every molecule which actually kind of blocks it. If you really look at it, it looks like a busy slide, but this actually is the foundation of your outcomes. Even if you don't want to know why this disease is, it's like your outcome. For example, you rub your eyes, you have a biological stimuli, that will change your epithelial barriers. Once you change epithelial barriers, the more of inflammation goes in. More of inflammation causes again release of a loop mechanism, the very cells, then it goes back again. Then all your inflammation which goes back reduces your lysyl oxidase, collagen, and once it happens, it shuts down your endogenous cross-linker. Basically what it does is, it just shuts down this. That means once you shut it down, even if you do cross-linking every year, it's not going to work. That's the beauty of knowing these pathways, and then a feedback mechanism. This is exactly what happens, and this is how new drugs, new therapies, new molecules are found. Because if you can block all of them, for example, if you can block inflammation killing your cells, you don't need cross-linking. The cells itself can regenerate. That's the beauty of our human system. So many times you need all these procedures because you are trying to actually induce from outside. Anything which you induce not naturally is not going to last long. So to answer the question, we looked at a lot of factors. The cornea itself, which I just mentioned, the genetics, the tear film. I mean, these all factors plays an important role in predicting why is your outcome good, why is your outcome bad. And without them, your outcomes, it is not your machine. The most important thing I want to give a take-home point from this talk, or my colleague's talk, is there is no problem with your machine or technique. It's a very simple procedure. Outcome differs because of these four arms here: your genetics, your molecular factors, your tear film, and your nutrition status. And for the next few slides, this is what I'm going to talk on. My colleague made this video for the ASCRS. He talks about three important things: your genes, what you get. That's why it's very important to look at when a child comes and you're not sure whether the child is going to get keratoconus or not, or whether you want to operate now or later. The best indicator is your parents. You do a scan of the child's parents. For example, this person is having keratoconus and you don't know whether to jump now and do it or not. We may have algorithms, but when you do your parents, her parents, and if the parents have a signs of aborted keratoconus or a form-first keratoconus, you know it's genetics. See, that's how you know that your outcome is going to be good or bad. Epigenetics is your inflammation. It's your environment, the way you live, where you work. Eye rubbing is just a mix of, it's a trigger. So, for example, I don't know. So what does this model teach us? How do we take this model to the next level? It helps us to understand that the most important thing about this model, when you have a bad outcome or a good outcome, you had to go back and ask all this question. There's something called as a white inflammation. which we need to keep in mind, where you don't have inflammation, the signs of inflammation, but it's still happening. The work is still happening. Your immunity is driven by your nutrition. We are the only clinicians who do not ask for all these things, all the nutrition status when we operate. We assume that is not needed, but you need it, and that's what I do. So ideally, you have to look at biomarkers and all these factors which you have mentioned in the past, but it's not. We are not in an ideal situation. Do we have? So what we do is we look at an ocular surface disease score for these patients. If it's high, MMP9 kits are available, but again, it's pretty costly, so it's not practically right. So most important thing is look at the systemic factors, ask a detailed history, be a good listener. Do you rub your eyes? Which side do you sleep on? See, there are patients who have unilateral keratoconus. They have high IgE, and they keep sleeping on one side, and that eye increases because they may be having allergy to bed bugs. They may be having allergic to cotton. They may be having allergic to factors which may them to trigger. So that is what we need to look at. We also looked at this paper. This was one of my first papers where now it's picking up. What happens is when you have all this inflammation, it's changing the collagen. So your cross-linking sometimes don't really work. So we started giving them cyclosporin drops. Cyclosporin drops did reduce the MMP9 activities, and this paper was published in IOBS 2015, and it says that there is still a role of when you want to wait for a patient and you tell them you come back after 6 months or 1 year. We don't give them anything. The patient still rubs his eyes, still the inflammation is on. So what I do is I give them, sometimes if they say that they have an eye rubbing, I had to block one part of it, like an epigenetic part of it. Then giving a cyclosporin drops does help, and we have shown that the topography also stabilizes because it changes your collagen. Anything which changes your collagen will stabilize your topography. Anything which changes your lysyl oxidase, which is an endogenous cross-linker, will stabilize it. So in a child, giving this drops also, at this point of time, we don't have more targeted approach, which works only on collagens or LOX, but giving this still helps to improve your outcome. And this is what happens when you give them. For this is a patient who was posted before surgery. You can see those are dendritic cells, the nerves are inflamed. We gave them the dendritic cells reduces. And once you know that you cooled it down, I call it preparing the bed for the surgery. You have to prepare the bed, prepare the patient for the surgery, because if you do it in this phase, your outcome will be like haze, pain, irritation, epithelial defect not resolving, persistent erosions, everything you want, you'll get it because the eye is inflamed. So I'm taking you from a different angle. When we say, especially when we are removing an epithelium and we say that as smooth as butter, it just comes so easily. I don't use alcohol, I try to use lasers only in special conditions. But as a scientist, you should always say what temperature, because this is the reason I said about this is, imagine there are two ways of removing the epithelium. One comes very easily when you're doing cross-linking, PRK, whatever you want. One day when we were doing this, I said, which one should I be happier? Most obviously, people will say, this is what I should be happier, because it comes so easily like a capsulorhexis. And, but when we did this study, we noted this patients, and we graded it into, based on tactile, there's no grading system. One which comes easy, one which comes quite tough, because it was in the same hand with no alcohol. And we looked at the outcome. We took those epithelium and we started, we did the analysis also. So what happens is, when you have an epithelium which comes off very easily, it also heals differently, because epithelium which comes easily is filled with inflammation. There are patients who had chronic eye rubbers, the healing is different, and we assume that they also would end up with having more scarring. So epithelial removal, when you are actually doing an epithelial removal, it gives you a great insight into probably looking at what I should do. So when I see epithelium coming loose, and when we document in our file that epithelium has come out loose, I tell them, Let's start the patient on long-term steroids for them because he's going to get scarring, he's going to have a slow healing. We'll start on tablet doxycycline because doxycycline works on MMP9s, it works on a lot of these inflammatory molecules, and we keep them on cyclosporine for at least 6 to 8 months. The reason is I know that these patients would heal differently from an epithelium which is hard. That is the first sign of when you're actually doing a procedure. That's the first time, because that's the reason I said do not be always conscious. There's a difference between the conscious mind and the subconscious mind. The subconscious mind is not aware of the present. The conscious mind is aware of the present. So that when you're removing an epithelium, the conscious mind should be active because you'll pick up a most beautiful thing which will help you greatly in your outcome. And this is what we found. I wanted to do this because, see, gut feeling you had, it works that way, but we just wanted to do this and prove it that what we are saying is right. That means the loose epithelium were filled with more inflammation. The always question is what is normal and abnormal based on what we saw. The mechanism of haze is all about, I showed you the dendritic cells, the Bowman's changes, how you activate and all this. It is not always your calibration machines. People say, okay, my machine is wrong or my riboflavin is wrong, I'm getting more haze, more. It's not always there. Do not keep blaming yourself for the factors which is beyond your hand, beyond your limits, because these things is difficult to understand. But I'm presenting it because I just want to do one thing, is to stop blaming everything on ourselves or machines. So for example, demarcation line. Demarcation line is nothing but the graveyard of keratoconus, graveyard of keratocytes where they die. And each procedure has a different thing. For example, once you do immediate, this is pre-cross-linking, I did confocals on them. Immediately after you do a cross-linking, you have keratocytes die, 90 microns, and they take at least 1 month for them to regenerate to the same level. So what really happens is, this is your graveyard. You see that there is no keratocytes, you see refractile thing, they're all collagen. It's the only time you see collagen because there is change in your refractive index at that point of time, and confocal picks it up. And so that having a lower or upper does not mean that you are doing great. It just means that how your wound is healing. So keratocyte death does not always indicate a great procedure. In that person, your wound healing is different. Some person may not have a death of keratocytes at all. He may have a different way of it. The reason is, this is a work done by Natasha, and when she was a fellow with me, is about how the wound healing happens. There are molecular pathways of wound healing. And if you have more inflammation, your keratocytes death will be more. If you have less inflammation, your keratocyte death will be less. So when you go back tomorrow and see that if your patient had more eye rubbing, irritation, you'll see that your keratocytes demarcation line is different. That means the person's immune tolerance makes him to have different depths of keratocytes death, because it is not the great thing to have death in your eye, because it has to regenerate. And you can see that this is the way the normal wound healing happens. It's even your PRK. She worked on PRK haze here. It was not on keratoconus, but it's the same. If you have your body's immune response triggers off how you're going to heal. That is why you get this normal and abnormal. And this is what happens when you have a bad one. Here the myofibroblasts have not reconverted, it just made it into a scar. And this is exactly what happens when you have this patchy scarring. What we get is because these patients had a different immune profile. And if you look at this, the immune profile is these patients have a different genetic profiling to cause scarring. Exactly same thing happens in the PRK, and exactly same thing happens here also. So that is something, and vitamin D is a major factor. That's why I do it for all my cross-linking patients. You can see that it helps to block the myofibroblast conversion. This is a major player. It is a very important player in converting in a lot of wound healing, especially in your cornea. And you can see this is a pathway which has been published by Sham Chaurasia group when he was in Singapore. Now he's in Colombia, I think. And so this is how it works. The question always is, which is stronger? Because we always been inspired by this thing from Wollensack's lab. Okay, you take a cornea like this, which is dull and fragile, suddenly it becomes stronger. Why are we not getting this? And that is a big question. We never see, none of us have seen this kind of a strength in a cornea. The reason is not the procedure, reason is your machines. We do not have a machine yet which can pick it up. And when we started doing modeling, mathematical modeling used this, which Rushad had worked with me on this, we saw that it is picking up, it is showing a change, but not like the picture you saw in the previous scene. It is a little different, but we need better tools like Brillion, which looks at every area of weakness and then how it takes it forward. The most important thing we need to know is, even though you have a keratoconus in your cornea, the pattern of disease is different. It's what is different in the cone is different in the periphery. So it does not really look at the same thing. So you have two different things in your cornea, even though you label it as KC. What we said is the periphery of the cornea looks like a normal one in molecular signature, like the collagen and other things. The center is what is different. So when we look at what really happens after us is, like I mentioned about all this, I'm just going to rush in a minute. So if you have all these things happening, your lysyl oxidase collagen still is a loop mechanism. It blocks it. Your cross-linkings do not work. So what is important? How do I block this? Be very careful about treating them. This is how the lysyl oxidase is. In normal corneas, it makes it, it's like a rubber band. It holds your collagen strong. If there's no lysyl oxidase, it's just floating around. The collagen is floating around, so you don't get cross-linking effect. When you have a video, it doesn't play. So you basically have to treat it. This is what we do. I'm talking about after the procedure, and then, or before the procedure, and then cross-linking. That is something which we have to look at. So when the topography keeps changing, even after cross-linking is done, we call it as progression, but this is the definition of progression. I'm sure Rushad is going to talk, but more than one diopter, you have to understand there's a repeatability issue also of the machines. And this is a patient who progressed very rapidly after cross-linking, and we need to understand there's a huge factor of genetics out there. And please do not blame your machine and keep cross-linking all the time. All I do is, when you have a progression, just take a parents and just do a topography, you will get the answer. Mother or father, one of them, the phenotype would have had an aborted keratoconus, which probably they have never seen. Then you know that why this patient is progressing. Every single patient of mine who progresses has a definitive topography phenotype in the parents or grandparents or siblings. And that is a very important test to be done when you do any procedure. Like I said, wait for at least the haze to go. I wait for at least 2 years to decide whether it's progressing or not, because the haze and wound healing messes up everything. So till 2 years, please do not jump and label them as progressors. And infections, dreaded, any procedures we can get infection. And what we publish is, I don't know why, but they become completely resistant to known antibacterials. Maybe cross-linking has to do with, I don't know, to ocular flora, but that is something which you need to know. So we explained a lot of this. Hopefully, the take-home point is, understand that immune healing in each person has got a different tolerance, and that plays the most important role in how you avoid or how you get it and how you manage these things after procedure. Thank you.
Thank you, sir, for that wonderful talk. Any questions from the audience? Yes, sir.
We shall get ready. Yeah, I think there is a case on this, and I didn't want to go too deep because I didn't want to take her presentation off.
So I also had one question for sir. Vishal, you can proceed on stage. So what do you exactly tell patients regarding the immune workup, and what are the immune tests that you routinely do for your patients? Sir?
That's the reason I started off my first slide. Do we still believe it's non-inflammatory? I don't believe it's non-inflammatory. So I tell my patient it's immune and inflammatory driven. So if you get a patient of uveitis which is chronic, it is the second attack of anterior uveitis, what would you do? You would test him for an immune workup, right? You would get him an RA factor, you get him a collagen muscular disease. So you don't, exactly what would you tell the patient? That it looks like an immune problem to me, I want to check it out. So 2 things I do for them is I do an IgE and vitamin D. Both plays a very important role. Both have a kind of it's a devil's axis. And the reason I do only 2 is these things I can manage. And if they're vegetarian, I do a vitamin B12 because it changes a lot in the neuropeptides. And neuropeptides are necessary for the regrowth of epithelium. Epithelium heals normally, there is no haze. The culprit is always the epithelium.
Thank you, sir.
Brilliant microscopy uses hydration as one of its factors to look at different levels of changes in the texture of your corneal collagens. It is like your topography. It takes different areas, whole cornea, and it tells you which area is strong, which area is weak. It is hugely a research tool. For one patient, one eye, it takes 35 minutes to do. So you need it. It's very difficult. But there's a group in US which we are working. Hopefully next year we should be having it, where they're trying to get a faster processor. It is nothing but a biomechanical tool, but your topography, like how you have your topography map, it will tell you. But the Corvus has got an update now, which will be probably testing it from next month. It can check 4 superior, inferior, lateral, and temporal, where you can look at the biomechanics, but not more than that. But Brillion will give you the whole area. Thank you.